The IMPERIAL study was conducted in order to look at a novel polymer-coated paclitaxel delivering drug-eluting stent, and comparing that to the existing technology, the PTX stent, which does not have a polymeric coating and has a much shorter delivery time period. The polymer coating of the stent allowed for a longer elution of paclitaxel and more tuned to the SFA restenosis peak, which is around 9 or 10 months. The study was designed as a 2-to-1 randomized trial of Eluvia versus PTX in a population of patients with SFA and proximal popliteal artery disease. It was a fairly representative population of patients with 30% CTOs, 60% moderate or severe calcification, 8 to 8.5 centimeter lesion lengths, and we think it was a good sample of patients for whom we could test the hypothesis between the two stents. The findings of the trial actually were quite impressive. There were no safety signals specifically regarding either stent, but in the Eluvia arm, there were 50% fewer clinically driven target lesion revascularizations, and there were a significant trend to lower vessel thrombosis rates. There was about a 2% rate of positive remodeling in the Eluvia arm, as analyzed by Doppler ultrasound at 12 months. So that was a safety profile. By and large, there were no major safety issues. Everything happened at a very low rate. From an efficacy standpoint, which is what we really want to know about, the Eluvia stent met its non-inferiority margin. That is, that was a primary endpoint of the trial, was to compare non-inferiority to PTX. Having met that margin, a pre-specified post-hoc superiority analysis was invoked, and that superiority analysis showed that, in fact, Eluvia was superior to PTX with a roughly 9% delta of effectiveness at 1 year. The results of the trial are interesting, and when you put them into context of what exists today in the management of SFA disease, it's a complex matrix of options available to patients and their practitioners. Atherectomy, drug-coated balloon, bare metal stents, PTA, and now DES in 2 versions, a drug-coated stent and a drug-eluting stent. I think since we are now talking about target lesion revascularization rates in this trial with Eluvia of 4.5% at 1 year, we have approached what we have seen in the coronary revascularization rate. And I suspect that this will change practice, especially in the moderate and complex lesion sets, where stent implantation and scaffolding is an important part of the patient's therapy, and where DCB and stenting was previously done with effect. This can be done in maybe one step rather than in multiple steps. You know, most research always brings up the next research. And so we now have a very effective drug-eluting stent as compared to the one that exists previously, both very good and very safe. And I think the unanswered questions will be, how does this compare to, let's say, DCB with a programmed stent implantation? Is there a favorable profile there? What about combination with atherectomy and more complex calcified lesions? How does it compare with Shockwave, which is a lithoplasty balloon? Is there effectiveness there as well? So you start talking about combination therapies, you start talking about other comparisons with antiproliferative therapies that currently exist, specifically DCB, and it gets very interesting very quickly.